And we've now got Michael Sykes, who's Vice-Chancellor's Fellow and National Audit Improvement Lead at Northumbria University and National Diabetes Audit, with Dr. Bethan Copsey, who's a Principal Medical Statistician at the University of Leeds. And they're going to be talking us through evolving a national diabetes learning health system, lessons from trials embedded within a national audit. So over to you.
Thank you very much, and thanks for the opportunity to speak this afternoon. I'm just checking you can see my slides okay?
Yeah.
Fantastic. So in England, 3.8 million people have diabetes. They are at risk of costly, but more importantly, life-altering and life-shortening complications. To improve care for these patients, the National Diabetes Audit provides feedback at a team, system and national level. It's one of 60 national audits in England, and like other audits, it provides additional support for improvement. I'm Michael Sykes.
I'm Bethan Copsey.
Thank you, Bethan. Seamless. And we'd like to describe our work with an evolving national diabetes learning health system. The punchline for this talk will be 2 calls to action. First of all, that we should be ambitious in our integration of practice and research. And secondly, a question to services. Do you want to discuss using your routine data to evaluate improvements? If so, please get in touch with us. The use of randomisation to assess improvements as part of routine work isn't new. So the Behavioural Insights Unit did work with the organ transplant service. And if you've applied for a driving licence update recently, you may have seen a message like this. You'll actually have received one of these 8 messages, because what they did was they randomised who got which message, and from doing so worked out that message 7, which said, if you need an organ transplant, would you like to have one? If so, please help others, would lead to about 96,000 more people registering. So routine randomisation, helping them to identify what was the best way forward. Back to you.
Great.
Thank you, though, for everybody for bearing with us for that. So this was different approaches that they used to try to support more people to register with the organ donation registry.
So we've taken some inspiration from Langone Health in New York, who developed a learning health system looking at targeting different things. So they look at lots of different things that people within the health service suggest. And so one thing that they've looked at is adding to the reminder for smoking cessation prescriptions that it's a billable service in their reminder, which has meant that over 1,800 more people got these prescriptions. Or similar strategies looking at discontinuing mailed reminders, which saves them $25,000. And using telephone outreach, which meant that 392 more appointments were scheduled.
So what we wanted to do is, if we could we similarly test different strategies to improve care? So what we're going to describe now is 2 trials that we've run with the National Diabetes Audit. The first is looks at how you might increase the use of insulin pumps for people with type 1 diabetes. This has been NICE recommended care since 2008, and yet today there are about 60,000 people with type 1 diabetes who are eligible according to NICE guidance, but that don't use a pump. They're receiving care from about 140 specialist diabetes teams. That was in England and Wales. The second study, EQUIP2, looks at the care for young adults with type 2 diabetes. Here, what we find is young adults have a more aggressive phenotype that increases their risks. By coincidence, there are also about 60,000 young adults who have a blood glucose level above what NICE would recommend. They're receiving care from 6,500 general practices that are part of 1,263 primary care networks. So looking at that first study first, what we wanted to do is to find out if we provide a quality improvement collaborative to those specialist diabetes teams, would it increase the use of insulin pumps? So we invited teams to take part, randomised them. Half of them got part of the Quality Improvement Collaborative now, and half of them will get facilitation later. We sought to assess effectiveness, cost effectiveness, and we looked at the processes of implementation. So 77 teams applied, we randomised, and what we did was to use routine delivery. So the Quality Improvement Collaborative was already going to be delivered, and also routine data. So national audit data of outcomes that helped us explore the data by ethnicity, age, sex, deprivation. And we also conducted interviews, observations, and documentary analysis to find out how it went. In Equip 2, we've been more ambitious, or even more ambitious. Here, what we want to do is find out, should we be providing primary care networks with webinars, with e-learning and email support, or with facilitation later? Again, we explored effectiveness, cost effectiveness, and processes. This time what we did was got permission to randomise all primary care networks in England. So a third of them got invited to webinars, a third of them got e-learning, and a third of them will get facilitation later. The content of the webinars and the e-learning is almost identical, so it draws upon learning from high-performing primary care networks, learning from young adults, and help to identify, so searches to identify patients, best practice guidance, and more. Again, we use routinely collected national audit data to assess the effectiveness of the interventions we were delivering, and carried out interviews, observations, documentary analysis, and surveys to find out how they went. I'll skip over this, but that's the logic model. Happy to talk about it later. So there were a number of lessons from this work. The first we'd like to highlight is how we aligned timescales. So it's a rough timescales for the process, starting in January 24, when the National Diabetes Audit set the topic of young adults. We then worked with them to design the study and the interventions. We pulled together a funding bid that went in at the end of July. Alongside that, we had discussions with the Health Research Authority. We got the good news about funding in January. We were then able to refine the interventions and undertake contracting and permissions. We randomised in April and start delivery in April. What I'd like to do is just kind of maybe contrast that with what would happen previously. So in the past, the National Diabetes Audit would have set the topic around October time. So about eight months earlier, we'd have designed interventions and done delivery. So there's a cost in time for the National Diabetes Audit. On the other hand, they get to find out more about whether they should be doing this again in future.
So by conducting the trial within NHS England, it gave us advantages in that we had increased data security, so data wasn't leaving the NHS England systems, which allowed us to accommodate large data sets as well. There was a talk this morning by Ella who talked about coffee and code sessions, and I think really echo the advantages of that, of having other researchers who were using the same data set brought a lot of benefits in terms of sharing code and ideas about processes. And being able to use the routinely collected data meant that we could include more patients in our study and have less work for all of the healthcare sites involved as well. We did have some unforeseen challenges, like always. So one of these was looking at HbA1c measurement, so the blood glucose measurement. There were some issues with the laboratory devices that were used to assess this in quite a few of the NHS trusts that were included in the study. So we had to sort of keep on top of this in terms of sort of having ongoing information and communication with the data providers about this. In the end, we were able to conduct sensitivity analysis because it was only right at the end of our study period where these issues started. So we could just chop out that bit at the end and see what would have happened without that. Another challenge we had was assigning patients to a specialist team. So within the National Diabetes Audit, specialist teams submit manual returns with the patients who are under their care and their data. However, we found that about half of the patients in the National Diabetes Audit weren't assigned to a specialist team. So we conducted 2 analyses in the end, so one with the data that was provided using the manual returns, and then we also used HES data, hospital episode statistics, to try to match people with where they'd received their most recent outpatient appointment, and assumed that that was the team that they'd been seen by.
There were obviously clear differences between the 2 studies, which I'm going to go through very briefly, which is one, we recruited teams first of all and then randomised. In the other one, we got permission to randomise them all. The implications from this about kind of permissions, about which ones reflects real life, and I'd suggest that the latter one more so. There were complications for power we can get into and also fit with ways of working. But conscious of time, I'm going to move on to the next slide, if that's all right, Bethan. Because there's a risk that we talk about the technical side, and actually this has really been more relational work. It's really involved a strong collaboration between NHS England, the National Diabetes Audit, Diabetes UK, and researchers, each of whom share common curiosity and improvement goals. They've each been tolerant of disruption to their processes, and it's also involved the development of trust. We needed to believe it was possible, but also really importantly, there was equipoise. That's this idea that we've been providing quality improvement collaboratives for a long time, but we don't know that they're better. So we should find out whether they're better or not by comparing them against not providing them. And so that equipoise issue is a key element to the process. As I said, this wouldn't be able to happen without a long number of people, many of whom are named here, and very grateful to the funder. But what I want to close with is those calls to action. So first of all, we really should be ambitious in how we integrate practice and research, because it's the only way that we will continue to get incrementally better, by knowing whether what we've done is better than what we had before. And the other is, we're doing this with one set of routine data and one set of routine intervention delivery. If you're doing similar work or you'd like to discuss what we've been doing, we'd really, really like to hear from you. Thank you very much, and apologies for the technical issues at the beginning.
No, thank you both, and yeah, thank you for persevering with us while we got that sorted. We're gonna need to move to our break now. But if with Michael and Bethan and with all of our speakers, if you want to reach out to them, you can do using the People tab in the program. So please do reach out to them directly. Any questions on that brilliant talk? Thank you both so much for that today. So we're going to go to a short break now. We'll be coming back in promptly at 3:35 for the final session of HACA2025 around improving flow. So hopefully see you there then.